was a disclaimer. Thank you, Deborah. Anyway, so thank you all for inviting me tonight to do this. Those of you that know me know that this is a topic that is sort of near and dear to my heart, not healthcare reform, but advocacy in general. And so let me preface this by saying that by the time the talk is finished, those of you that know me may be a little surprised that Scot Glasberg actually gave this talk, because those of you that know me know that I was pretty opposed to healthcare reform and the ACA when it was being debated 3 or 4 years ago. But I think the reality for everyone has set in, needs to set in, that the ACA is here. There are small bits of it that may get repealed or changed slightly. But 2013, 2014 is a very big year for healthcare reform, because that's where the implementation, the rubber really hits the road and everything starts getting done. So that's where my talk is going to start to focus, and so we'll just move into it. Sorry, my disclosures, not that any really affect the purpose or content of this talk. So let's talk with what we all know about, and then I'll probably get into some things that we've sort of heard about and some verbiage that you may have heard about. But I'll get high level, and then I'll sort of get into the sort of more of the nitty-gritty details where I think that plastic surgery and plastic surgeons really need to step up, especially those in private practice. So we know that the SGR, that's sort of, even though it's 3 letters, it's a 4-letter word. It's the formula upon which sustainable growth factor that has sort of been the bane of existence of all physician payment formulas. It starts with Medicare, and then all of the other insurers follow it. The problem is, without getting too detailed into the math, is it's a formula that's based on volume, and it never took into account that healthcare would continue to grow because there are more people and more physicians, and people get sicker, and some of the costs have just risen dramatically, and so it's just a bad formula all around. So the one thing that I think everybody, no matter what side of the aisle they're on, agrees in is that the SGR needs to be repealed. The problem is a new formula that's going to be more reality-based, and there are proposals out there like something called the MEI, which is the Medical Economic Index, which bases its formula on sort of more things healthcare related, more inflation related, more typical what I call cost and expense related to present day time. But as everything in Washington goes, it's all about the money. So back in 2002, when we started talking about the SGR, the repeal cost at that point was $50 billion. That's just to take away the SGR, not even to implement the new. That cost grew into 2012, to $400 billion. So given where we are with the debt and given where we are with everything else going on, $400 billion is just not a number that anybody's happy with on Capitol Hill, and it's a number that makes everybody sweat. And so the one thing that's actually happened in the last, I'd say, 3 months is the CBO, that's the Congressional Budget Office, they're responsible for putting a cost on everything, has actually come back and said that, you know what, those costs might have been inflated, and maybe it'll only cost us about $135 to $160 billion to repeal. Now, still a lot of money, but in the scheme of things and in the scheme of where our budgets are today, that's not as big a deal because they're thinking, wow, that's a 50%, 60% savings, so maybe we should jump on this thing now before we let it grow too big again. And the other thing that's happened is Capitol Hill, the legislators in the House and the Senate are just tired of hearing from physicians and tired of putting these sort of one-time Band-Aids on that they've done every year to fix the SGR. So what they're looking at doing now is they're getting really serious about repealing the SGR and coming up with an alternate formula. So much so that they're looking at physicians. I was just in D.C. 2 weeks ago, and I met with the AMA, and I met with the college, and I met with some staff of the legislators in both the House, Energy and Commerce, Ways and Means committees to talk about some of the proposals that are sort of being bandied about. One of the big downfalls, second bullet point on this slide, is that unfortunately, despite multiple promises, the SGR was not dealt with in the Accountable Care Act. And that's unfortunate because that was the place where it probably should have gotten dealt with. And the AMA, no matter how you feel about the AMA, positive or negative, unfortunately bought into a promise from the legislators that it would be repealed sometime shortly thereafter. And here we are 3 or 4 years later, and it hasn't been repealed yet. And we know, promises on Capitol Hill are about as good as, selling you the Brooklyn Bridge or something along that lines. So the SGR really is the focus of all healthcare reform issues going on the Hill right now that relate to physicians. And it's probably the basis for what a lot of them of what healthcare reform is going to do and how it's going to affect physicians moving forward. So you've all probably heard of IPAB in one way, shape, or form. And IPAB is probably the single most dangerous thing in the Accountable Care Act. And what it is within the Accountable Care, and IPAB is what you probably heard about, is it's an unelected board of 15 what I call bureaucrats who are appointed by the administration, by the president and his advisors. And it will oversee Medicare moving forward. Now, the question is, why is this so dangerous? Well, elected officials, as we all know, tend to sort of worry about what their constituents, be it regular, elected public, or physicians might think. An unelected board doesn't have to answer to anyone other than themselves. The other thing is right now there's a body called MedPAC, which sets policy for Medicare on the Hill. And the legislators have the ability to mold that policy the way they see fit, where costs are involved. The problem with IPAB is unelected board, appointed by the administration, and Congress would only have the ability to vote up or down on the recommendations. So if, Medicare were tight for money and, Congress said, well, we need to cut $50 billion from it, but IPAB came back and said, no, we need to cut $1 trillion from it, they would have to vote up or down, and it would put them in a situation that's pretty uncomfortable and could mean some pretty drastic issues with regards to how Medicare and physician payment moves forward. There is tremendous support on Capitol Hill, and I would say pretty bipartisan right now, to repeal the IPAB and go back to the old method. And when I said earlier that there are a few things we might see change in the ACA moving forward, this is probably the number one thing that I could see changing. In fact, there was a vote in the House and Senate about a year ago that would have repealed IPAB, but because of politics, and unfortunately we can always have to put up against politics, the Republicans decided to attach other things to the bill, such as medical liability reform, and the Democrats wouldn't vote for it, so it failed. But there is a sentiment right now that could repeal IPAB sometime during this year's session, and I think pretty much everybody agrees that this could be repealed. That would be something very positive in healthcare reform. This is the big one. If you haven't heard about it yet, you're going to hear about it soon. And this is this value-based modifier. And in simplest terms, what it means is that all payments moving forward from about into 2014 and forward are going to be based on some type of value-based payment modifier. Now, this is a pretty tricky thing because you look at that and you say, well, what does that mean? And value to us is not necessarily value to people on Capitol Hill, especially legislators who don't understand clinical arena. But what it means is they're going to have to find some link between the way you get paid and the way payment is implemented. And it is things such as quality measures, we've all heard that we would have to code, in addition to the way we currently code cases, to show that we've done what are called meaningful quality attempts at care that are accepted by everyone. Now, the obvious question comes to mind is, A, who's going to come up with these quality measures? And there are numerous groups out there, like you've heard of, NISQIP and things like that, run by the college and whatnot, who are coming up with these payment quality measures. But it's a painfully slow process. And where it really hurts us, and this is where I'm going to start to get into plastic surgery in general, is if you look at, let's say, our journal, where you would hope to find some of these quality data measures, there are different levels of evidence, we all know, and most of the evidence is unfortunately only level 3 or 4 evidence. So coming up with measures that we can all agree to, it's a very, very difficult task. There's also the issue of, how will these quote-unquote quality measures be attributed? How will they be assigned to people? Will they be assigned the same way to someone that does 100 breast reconstructions a year as to someone who does one? And then there are other, issues such as, who's going to determine that? Because right now it would be IPAB. We don't want that. We want it to go back to the MedPAC way. But also, who's going to be assigned the bigger risk involved? So, what I mean by risk doesn't necessarily mean what you think it does. What it means is that, does it mean that, if you do a breast reconstruction, that somehow the breast surgeon will be, quote unquote, a more important part of the care, so they will get a bigger part of the pie than the breast reconstructive surgeon, who may not be as important to certain people. So a lot of those things still need to be worked out, and a lot of those things still need to be accounted for as we come up with these proposals. And that's a lot of the things that we were talking about when I was in D.C. last year, because people on Capitol Hill, excuse me, just getting over a cold, just don't understand what's important. And then the last phase is, where does the patient fit in? Clearly part of these value-based modifiers, quality issues moving forward, there's going to be some assessment of patient satisfaction. So that's clearly going to be important moving forward. But beyond that, suppose you just have a non-compliant patient and they have a complication, and it's directly related to whether they did or didn't follow instructions. Somewhere that needs to be taken account for as well. And so that is going to be very subjective and somewhat difficult to put into this formula. So you can start to see where this can get very, very tricky, very, very difficult. But the reality is, and what I'm hopefully here to tell you, is that this is a train out of the station. This is going to happen. And the most important thing from a medical organizational, specialty society organizational standpoint that we need to do is be at the table. Because the last thing we want is other people deciding this for us. So I'm going to start to get into some other aspects of ACA, and then I'm going to bring it back to plastic surgery. Accountable care organizations, you've all probably heard of. They've been around in the news for about 2 to 3 years now. There are about 122 that have been approved across the country right now. And this is when a group of healthcare providers get together and agree to accept joint responsibility for medical care, the management, the costs, and the outcomes, and most importantly, the risk. And what I mean by the risk is, these providers are going to get together and agree to treat patients by a certain standard of care, a certain, what we'll call, and I'm going to talk about this more, clinical integration pathway. And once they're treated that way, if they do really well and there's some cost savings, all of those people, all those providers will be able to share in the cost of the savings. On the other hand, if it goes the other way, you won't necessarily be penalized much, but there'll have to be a reevaluation in how you're taking care of those patients. And the difficult part for us in general, and this is specialty surgeons, is it's really run by the primary care physicians, right? Because they're the people, it says the ACOs must accept responsibility for at least 5,000 beneficiaries. The primary care physicians are the ones who are going to bring the patients into the mix when it comes to an ACO. When this was first proposed, you can imagine, as you've probably all heard, tremendous angst across the country. But because, everybody said, well, this sort of sounds like the HMOs from the 80s and 90s, and that didn't work, and isn't this going to just be the same thing? But the reality is, and I'm going to talk about it in a minute, the government has actually been able to show that these types of pathways do work and can come up with better and more cost-efficient care. The other thing is, again, train out of the station. We've got to buy in. We've got to be at the table so we can help mold it moving forward. I got to mention at the beginning that, and I've actually left the lines unmuted, you're welcome to ask questions because I wanted to try to create an interactive exchange here, but you can hold them till the end. If it's something critically important, I wouldn't mind you cutting me off and asking a question. So let's talk a little bit about quality reporting. This is this whole quality measures issue that I was talking about a couple of minutes ago. Delineated within the bill, it is clear that you will get payment reductions moving forward for not reporting quality measures. Currently, a system called PQRS that I'm sure most of you have heard of, if you report certain quality measures, and right now the ones that we could report related to plastic surgery would probably be DVT prophylaxis, proper use of antibiotic prophylaxis, and things of that nature. If you report them, and I actually started reporting them for about the last 12 months, you get a 0.5% uptick in your Medicare payments. The insurers have not yet bought into this, but I guarantee you when that 2015 date comes around, they will definitely buy in. And moving forward, according to the bill, you will be penalized. So in 2015, you'll lose 1.5%. 2016, 2%, and we don't know what's in store beyond that, but I'm sure the cuts will get significantly greater, provided there is some data to show that this quality reporting is actually working and people are doing it. The other big thing linked to quality reporting is electronic medical records. And this is where we as a specialty, plastic surgery and some of the other specialty groups have really fallen down. I would say to you, one thing right now is if you don't have electronic medical records and you accept insurance, the time is now to change that. I would say that probably, even if you're a 100% cosmetic surgeon, probably now is the time to institute an electronic medical record, because I think the whole system is going to go over so dramatically to electronic medical records starting in 2015 and beyond that you'll be at a big deficit without it. But clearly, if you accept insurance, all payments will be linked to the use of electronic medical records. And to be honest, the quality reporting is going to be much easier moving forward if you have an electronic medical records, if you need to, let's say, pull up a piece of data just from your practice that you may not have. And again, penalties involved with that as well. 2015, 1%, 15, 2%, and so on, forth and so on. So clearly, all payment moving forward is going to be linked to quality measure reporting and the use of electronic medical records. Now, they had put e-prescribing in there as well, but that requirement has sort of lapsed or sunsetted, and that e-prescribing is just going to basically be required by every state by 2015 anyway, so they're not giving credit for e-prescribing. So post-ACA passage, it's become this sort of potpourri of initials and algorithms and things like that. Some of them make sense, some of them don't, some of them are thrown around and interchanged, and so the whole list is sort of up here. But the one, if you were to take one bullet point away from this slide of the new language of healthcare reform, the last bullet point would be the most important, and that's efficiency. And again, you really need to change your mindset. Efficiency moving forward is not going to mean what efficiency meant to us in the past. So what did it mean to us, physicians, plastic surgeons in the past? It meant good care. It meant that you had good outcomes, that you were able to minimize your complication rates as much as possible. Maybe it even meant that you had some, your patients were satisfied, you were satisfied with the results. But the unfortunate reality for us moving forward is that efficiency is going to be linked to cost as well. And the reality is, and I'm here to tell you that I actually believe it, that by getting us more quality care can help reduce costs, and I'm going to go through some of these now. So the question everybody asks is, why should we change now? I've sort of made the argument that the ACA is forcing us to change, but I will tell you that the whole environment has changed. And if we don't change, we're going to go away, especially if you're in private practice. If you're an employed physician or an academic physician employed by a big university, they're going to make the changes that will probably help guide you. But it's probably pretty important for you to know individually what you're doing as well, because to succeed within those big systems as an employed physician or as an academic physician ultimately employed, you're going to want to know how your results are coming out compared to other people within the system, because it's going to probably mean your sustainability within that system moving forward. This is just an unfortunate reality. So that, if we don't get involved now, we will get left behind. And that's probably one of the more important messages I'm here to give you. So let's talk a little bit about the healthcare climate that I just was sort of talking about. Clearly, there's healthcare consolidation across the board, and that's going to even make it more difficult for physicians and specialists, plastic surgeons, moving forward. There's consolidation in the insurance companies. 10 years ago, for example, in my state, New York, there were 11 insurers. Today, there are 3, and I'd say 3.5, because one's already talking about consolidating. North Shore LIJ, the system that my hospitals belong to, now owns 17 hospitals in my area. 10 years ago, they owned 2. It's the unfortunate reality that everyone wants to become the biggest, everyone wants to be the best, and biggest doesn't always mean the best, but in their eyes it does, but it definitely gives them power. The other thing that's happened so dramatically over the last 3 or 4 years is the number of employed physicians. In my system, North Shore LIJ, they bought 250 private practices across the specialties in 2012. That number is projected to be 450 in 2013. The other thing that they're doing is they're bringing in hospitalists. Argue what you may, the reality is that there's some data out there that suggests that hospitalists are able to create, and I say this in parentheses, better care from an efficiency standpoint, and so that's why they're using them. So if we don't adjust our practices to address all these issues, again, they're going to overtake us with these other things. And now the last point is, one that I think is definitely true in some other specialties. In cardiology, it turns out, I was amazed by the statistic, 5 years ago, 40% of cardiologists were employed by systems, hospitals or systems. Today, 86% are employed by hospitals or systems, 86%. I think plastic surgery is really the last bastion of private practice. We have, a certain ability to maintain that, provided we stay at the, sort of edge of the game and up with all of the things that I'm pointing out. Why? Because we still have the cosmetic side, which is fee for service that will never go away. But the other thing is I think that we have the ingenuity. There's no non-plastic surgeons on here, I hope. The ingenuity based on the way we market our practices and things like that, that if we really take note of these things, to really change our practices to stay current and whatnot. So I think we have an ability to maintain private practice that others don't. But our numbers are in private practice are going down pretty dramatically as well. So where do we start? And this is what I was intimating earlier. We really need a complete change of thinking. 10, 15 years ago, it was okay to be a surgeon, a plastic surgeon or any surgeon, and say, I do things because this is how I do it, and I do it because it works for me. We can't do it anymore. We have an era of change in healthcare reform. We have an era of evidence-based medicine and our approaches. And in order to really preserve our independence in clinical care, and I mean, private practice and things like that, we've got to develop clinical pathways, clinical integration that works based on evidence approaches. Because no one's going to ever buy into the fact anymore. When you're walking around the hospital and somebody asks you, why did you do this? And your response is simply, this is how I do it, or because this is the way I've trained to do it, or this is what works for me. We really have to become more moldable, more adaptable to the changing environment. So again, what does efficiency mean? It definitely means improved outcomes, because if we do and make all of these changes and our complication rates go up and whatnot, then clearly that's not efficiency. But the unfortunate reality, which we didn't want to think about 10 years ago, is it does mean decreasing costs. And I'm here to tell you that I think the two can go hand in hand. And it can the independence fits in there from our ability to hopefully drive the forces specific to plastic surgery to help make things better. So I mentioned earlier that the government's already shown that this can be done, and let me talk about a few of these. About 5 years ago when CMS, the Center for Medicare and Medicaid Services, announced that they were going to have these quote-unquote never events, right? Everybody just went crazy. It's not possible. You can't never have an infection. You can't never have this. You can't never have that. And sometimes that's true. But the reality is, and I give this talk in front of our audience, I ask, how many people have been on, the national website that looks at never events and looked at the central line infection rate at a place like the Cleveland Clinic or the Brigham? And the answer is, if you go on the site, it's 0. And it's not because they're lying. It's because they've made significant changes in the way they do things to get that rate down to 0. And so what's also happened is by taking a systematic approach to get to that, they've been able to decrease the costs and they've been able to show better care. So the government says, look, we told you it can be done, and it is being done. Same things happen with surgical site infections. The number one cause of surgical site infections right now in the literature appears to be things like the number of people that enter the room during a procedure, coming in and out of the room. In places where they've cut that traffic down, their surgical site infection rates have come down dramatically. Not 0, obviously, but pretty close. Antibiotic usage. The SCIP trials are,
Can I jump in? I'm sorry.
Yeah, absolutely.
It was okay, because I have a question. Because and I saw that that was an abstract at the ACS, the number of people coming in and out of the room.
Mm-hmm.
But if surgeons, and maybe I'm misunderstanding this, but if surgeons are being held responsible for it, I know, and I'm in academics, and I have 0 control over the breaks, which happen every 10 minutes, over who is in my room, whether it's somebody who's familiar. So how do you negotiate these never events when you assume the liability but you don't have the authority to institute the change?
So in my system, the way I've done it, because I looked at like I was from Mars when I brought this up to them about 3 years ago, I got myself appointed to the operating room committee at my hospital, and knowing that I had a certain few things that I wanted to see change. This was one of them. And I used the precedent of places like the Cleveland Clinic. I showed how it was done, where they have facilitators between the rooms so the circulator never has to leave. And they tried a pilot system, and they instituted it. Started in orthopedics, where they were having more surgical site infections. And when they did it, they were able to show that the rates came down. And so, you have to work within your hospitals. Keep in mind that your hospitals are under as much pressure as we are to cut these down too, because remember, if there's a surgical site infection right now, you still get paid, but the hospital doesn't. The reality is 3 to 4 years from now, we won't get paid either for those. So I think, this is one that goes back to, and it's something I'm going to say later, is, we got to work within the confines of what we have to try to make change the best way that we can. It's hard for a hospital in this day and age to argue against someone who comes to them and said, look, here's a piece of data. This is what's supposed to work better. We need to implement this. And, it takes a little struggle sometimes, but I think that's the way you got to try to get things done. And, the other thing is going to the other services and whatnot and trying to help implement that as well. That answer your question?
Yes, it does.
Okay.
Thank you.
So antibiotic usage is another one. Be what you may, think what you want about the SCIP data, but the reality is that was a very large, randomized, prospective level 1 data study, and multi-center, and the reality is they showed, proved, when is the best time to give antibiotics and when is the optimal antibiotics, and how long to continue them postoperatively. It has been so accepted across the board that in 13 states, such as New York, if antibiotic usage is not followed according to the SCIP protocol, the hospital gets dinged. And I guarantee you 2 or 3 years from now, the surgeons will get dinged as well. And until there's a study of equivalent caliber, and there are some being done, for example, the SCIP data didn't include an arm for breast reconstructions using implants. I know that's been a big concern. There is an arm now, so by the middle of 2015, there will be data on that. Although I will tell you, from what I've heard, the early data shows that it's exactly the same. The other thing is we've got to now compete with things like hospitalists, right? They work for the hospital, they follow clinical pathways, And there is data out there that suggests that they offer cheaper and quote-unquote better care because their outcomes are better, their complications. So we've got to mold ourselves to sort of go towards that as well. So it sets up a dynamic system of power between the physicians and the hospitals and the insurers. And if we don't take the lead, we're going to let the others, the hospitals and insurers, take the control. And they will win. They're bigger, they're stronger. But the reality is, and the thing that we have to realize is they cannot do it without us. But it does mean that, in answer to that question again, collaboration is going to be the key. So if, your hospital starts an ACO, Accountable Care Organization, and they want to come up with a clinical pathway for, let's say, breast reductions or something else, free-flap breast reconstruction, it behooves us to be at the table to help them come up with that critical pathway so they don't do it on their own. So it actually is something that works. But we have to, this all goes to that change of thinking. It has to be something that we're all willing to buy into. So what's needed? Well, we need outcome-based data, and we're still working on that, right? If we look at TOPS, for example, only, a small percentage of the plastic surgeons in the country give data to TOPS right now. And we need more evidence-based medicine. I think the foundation is working real hard on a yearly basis to give out grants to come up with higher evidence data so we could use that data moving forward for these reasons. And then we've all got to come to the realization that we're going to have to buy into clinical pathways. Now, when I was in training in general surgery, we had critical pathways for laparoscopic cholecystectomy and things like that. And back then, people were putting up a fuss, too. The reality is, at the end of the day, once they were implemented, they did really well for patients. Patients did well on them. There was decreased cost. Length of stay was decreased. That's the really big one. And what ended up happening was you had to either adopt or get out of the way. It couldn't be that, you kept your lap choles in the hospital 3 days when everybody else kept them 1 because everybody else was doing fine doing it at 1. So the goal doesn't necessarily change. The goal is still improved outcomes, but it is a mindset that with improved outcomes comes decreased costs. So we want to decrease our complications. Number 2 is the biggest one, I can't even tell you. In my practice, I now barely keep a patient in-house for some things that I know a lot of my colleagues keep them in for. So, for example, post-bariatric body contouring, circumferential body lifts, about 40% of my patients are going home the same day now. Another 40% are staying 23 hours, and another 20% will stay 1 night. Some of my colleagues have been resistant to this, and they stay 4 days. And what's happening is the insurers are looking at those and not approving them or referring them, trying to refer them elsewhere. So there has to be a realization that we've got to come up with these improved ways of taking care of patients within reality. Because if we make a move and it yields anything against this analysis, if it increases complications, then we can't do it. We have to go back and reevaluate. Number 3 is a big one. As part of the ACA, as part of these value-based models, there will clearly be a component on patient satisfaction. And the reality is as plastic surgeons, we are way out ahead of the curve on this one, thanks to Andrea Pusick and BreastQ and FaceQ. The models that have been developed through the foundation have really been admired by people at the AMA, at the college, and even on Capitol Hill. And we have talked to them about using them as models going forward. The other thing which we are doing, moving very strongly forward on both the ASPS and foundation side, is with registries to get outcomes data. That's something we're also way ahead of the curve. So there are elements that we can actually use as leverage in negotiations with groups that we're already doing as plastic surgeons where we're ahead of the curve. And at the end of the day, decreased costs, reality of the world, because that's what it's all about, whether we like it or not, and that ends up with a better efficiency, hopefully. So the new definition of care delivery is to standardize, and that's the word we all hate, right, as independent physicians and surgeons, right, to the science. In other words, take the science that we know, work improve, standardize to it in order to custom craft the art of medicine. So it's not anymore an art about individuals. It's an art about us as a whole. So true clinical integration is a term I've used several times. Physicians working together systematically. That's the big one we've got to come to accept, with or without other organizations and professionals, to improve the collective ability. Again, it's all about the group, to deliver high-quality, safe, and valued care to their patients and communities. So it is very different than the way we did things just 10 or 15 years ago. So what are critical pathways? And, the reality is it's a checklist and it's a cookbook. And it goes down to every detail of care, preoperatively, intraoperatively, and postoperatively. Okay, so it means, when does the Foley come out? Well, I take my Foleys out on day 2. No. Everybody says you can take them out day 1 and they do fine. They got to come out day 1. And the only time we really gain any independence is if somebody falls off a path. So what do I mean by that? Well, you do a procedure, you're in your critical pathway. They're supposed to go home 23 hours and they're having nausea and vomiting and pain. Okay, then you can have at it. That's when you have your independence to treat them, sort of the way you want. But short of that, it is really much like the pilot industry, where they get into a plane and they go through their cookbook checklist before they take off of however many items. And they say check, check, check. That's sort of the way we're going to be doing things moving forward, need to do things. So preoperatively, we need to try to minimize risk. And I'm just going to quickly go down this risk and rattle off a few things. And, you can think about whether or not these are things that you do in your practice. And I would put to you that, we probably don't spend enough time thinking about these things moving, because we're so busy with other things. Tobacco use, I think all of us agree tobacco is bad. And we probably all ask our patients to stop smoking. I ask them to stop smoking for 30 days preoperatively. Excuse me. But how many of us do that with alcohol as well? How many of us talk to our patients about alcohol? How many people make their patients stop using alcohol preoperatively? Well, the data out there that actually shows equivalency between the alcohol and tobacco use and the effect on wound healing and surgical site infections. Nutrition is another big one. Something that, when I was in training always drove me crazy. We would make these rounds and nutrition would always be at the bottom of the barrel. But the data was starting to pile up at how important nutrition is. Well, something as simple as realizing your patient is either cachectic or nutritionally imbalanced, and not because the patient is heavy doesn't mean that they're nutritionally balanced, but something as simple as putting them on a couple of Sestical, a protein shakes, for a couple of weeks preoperatively can immensely enhance. There's data to show can immensely enhance their wound healing capability postoperatively. Obesity is one that we can't always deal with, right, because some of these procedures are not always so elective. But the reality is that high BMI, it's higher complications. So getting patients to lose weight and waiting is sometimes a viable option. Diabetes, I think we all probably look at preoperatively, how the patient's H1AC is doing or how their sugars are controlled. But there's excellent data now to show that if you keep a patient in the hospital, it is much better in terms of wound healing and surgical site infection if you keep them on a IV drip of insulin rather than giving them those sliding scales subcutaneously. Steroid usage, it's an easy one. When I go to M&M, if a patient's on steroids, you always know it's the steroid's fault for whatever complication they had. Well, how many of us put our patients on high-dose vitamin A, starting preoperatively and maintaining postoperatively for wound healing when the patients have to be on steroids perioperatively? Easy, low risk, cheap, and definitely yields, according to the data, some significant benefits. Remote site infections, how many people would cancel a case if a patient had a small abscess on their back that was IND'd or lanced 2 days preoperatively? And then colonization with microorganisms, things like hair clipping preoperatively, when to do it, are all things that that we really need to take into account. I mentioned the SCIP trial, so we won't belabor that point. I think I made that point earlier. Intraoperatively, we need to be mindful of the medical devices that we're using. Are they truly of benefit to the case? Do we really need them? Is the cost in a long term, not a tunnel view of one case, but in the long term beneficial? Can you build an economic model that shows that somehow using this medical device is going to decrease your complications and therefore your costs long term? These are all things that we need to start to look at, not just letting the medical device companies do it for us. Operative time is a big one. There's lots of data out there now that suggests that cases that go over 6 hours really have increased morbidity associated with them. So, is it possible? Can we split up some of our cases? I know we don't always like to do it, but if we're going to go over 6 hours, maybe we should. Minimizing risk intraoperatively is important as well. Something I learned as I was doing this was that simply leaving a 4-needle nasal cannula on a patient for 2 hours postoperatively, and this is from the orthopedic literature, can decrease their surgical site infection rate by 50% in the postoperative period. 50%. I used to walk over to the patients and take off the nasal cannula and say, "Oh, you don't need that. You're just not comfortable with it." And now everybody who treats my patients postoperatively know that they stay with their oxygen for 4 hours post-op, come hell or high water. Hypothermia is a big one. Your patients come out normothermic from the operating room. I never used to ask an anesthesiologist about their temperature. I ask on every case now. Why? Because it's clearly been shown that something as simple as keeping a patient normothermic and having them come out above 36 degrees postoperatively yields a better surgical site infection rate and better wound healing. And actually in New York, one of, I forget how many states now that have laws, not laws, but statutes, saying that if they don't come out normothermic, the hospital gets dinged. Again, in the future, we'll probably get dinged, as the anesthesiologist will too. I mentioned this earlier. Length of stay is the big one. Early ambulation, early removal of indwelling catheters, early postoperative instructions. Patients get read my instructions in my office at their pre-op visit so that they've read them when they're coherent and not when they're post-anesthesia or whatever in the hospital or in the recovery room or whatever, because I know that they're going to understand it better. The other thing I do, quite frankly, too, is I preach to my patients about going home early. I tell them that hospitals are for sick people, and I've been able to get my length of stay in my practice down pretty dramatically by doing that. If you tell them, well, you could stay a day or two more if you don't feel up to it, obviously I'm going to keep them if they're not up to going home. But if you start to set that mindset in your office, it can really make a big difference. I gave you the example earlier of the post-bariatric body contouring patients. Same thing's true with my tissue expander patients. 50% go home the day of, 30% go home for the next in 23 hours. All the rest go home within a one-night stay. Breast reductions, obviously they all go home the same day. I don't use drains anymore. I never use drains actually, but I don't even consider drains because they haven't been shown to benefit. Again, patient satisfaction. Patients complain about drains a lot. All things that we just have to be mindful of thinking of moving forward. And we could have another hour or two discussion just on specific topics within plastic surgery where, I think that we could probably enhance the way we're doing things with almost minimal effort. So in summary, what's my message here? Well, we need a whole completely different way of thinking, and I mentioned it a bunch of times, so I won't mention it again. But I think that building efficiencies like I'm starting to point out, and there's much more to this, obviously, into our practices on a daily basis, into our thinking. And again, there's nothing wrong with having a checklist in your office to sort of, make sure that you've done everything. I do it in my office now. I've got my pre-op checklist, my intra-op checklist, my post-op checklist. It's almost like the timeouts we all have to do now in the OR. I thought they were ridiculous when we started doing them, and now I realize that they serve a purpose. If we build these checklists into our practice, I think we'll get better efficiency. I think we'll get better outcomes, and I think we will really drive our costs downward and make ourselves, viable in the current healthcare environment. And I think viable means survival moving forward, because I think if we don't do these things, those that don't will sort of fall off the curve and not, be sustainable. So again, I thank you for inviting me, and I'm happy to take any questions you might have. Any questions?
Thanks, Scott. I think that was really informative and a little bit scary from my standpoint, because a lot of us are in private practice, and it's hard to face those kinds of realities.
You there?
Yeah, I'm sorry, my dog is barking like
That's
crazy.
okay.
No, I just think, I mean, to a certain degree, you're right, because I think about like how I do my things with my free flaps, and my free flaps are very systematic and pathway-based. And I've tried to implement the same kind of thing to my other surgeries, but it takes work.
Right. So I think that, we've talked about at ASPS about, trying to come up with these pathways. We've gotten sort of busy with other things, but I think the rubber, like I said, hits the road now, and I think we need to continue within our committee structure to work on these types of guidelines and pathways moving forward. I think what you said, Nanu, was really important. I think that, the way I started is I started from my easy cases, and maybe even the sort of shorter cases that had a smaller list of instructions and things like that. And I set up a basis and or maybe the things you do most frequently, and then you sort of expand it out into other areas. Excuse me. I'm still working on it. I mean, for me, I think it's going to be an ever, evolving process moving forward. But I think that you're right about saying, if you can find something that you implement on a daily or do on a daily basis that already has that checklist sort of mentality, and free flap I think is a great example. Then you can start writing that one up and sort of take that to start taking it to the more and more difficult cases to implement protocols for.
Scott, this is Carl Gutowski. Thanks for doing this. What I found interesting is from what you said, almost all those safety and patient satisfaction things are nothing new. It's actually most of it's old data, everything from maintaining oxygen to normothermia and things. The biggest challenge is unless you're working in your own surgery centers, getting everyone on the team to buy into this. And I learned this when I started doing the post-bariatric body contouring, that not everyone realized how hypothermic the patients get and all the other little traps that come along with it. So I made a checklist similar to a checklist, and then before every case we had a little 5-minute or less team meeting so everyone knew what's going on. And after a while, people kind of got the hang of it. And sometimes you'd get anesthesiologists that didn't even think through the fact that the patient's totally exposed and we're working on 4 different areas. But once you have to, this is really, I guess what I'm getting at is you got to educate the team, not just the surgeon. And I think it's more than a checklist. It's everyone on the team understanding what the pitfalls are and why we do things the way we do and why we don't want to use drains, because then the nurses on the floor question in front of a patient, they'll say, why didn't you use a drain and stuff like that. So my thoughts on this would be educate everybody, when you're trying to implement this, and then it might work for you.
But
I think that's a great point, Carl. I mean, I think, and you reminded me, when I first started to implement some of these things, I took it to what we call, and I'm sure you all have different variations of this, our coordinating care council, and for the OR, and on that sits nurses, and sits management, and sits your purchasing people, so that everybody knew across the board this is what we were going to try and implement. And what it did was, once I was able to show that it worked for me, they started to say, well, we need to do this in orthopedics, we should do this in urology and whatnot. So you're absolutely right. It means educating everyone. And the one thing that I really believe as plastic surgeons, and I said this earlier, that makes us unique is I think we have the ability to sort of take the lead on a lot of these things, especially when it relates to our cases, obviously, but in general, in helping to educate, all the other surgical specialties and all the other paraprofessionals when it comes to this. I'm sorry, I cut somebody off, I think.
I just still, this is Deborah Becker, but not to perseverate on this sort of responsibility without authority, but even getting even getting everybody on board, like I will do a pre-timeout timeout. And like one of my things is DVT prophylaxis, and that the SCDs have to be on before induction. And then if I leave the room to do anything, to go to the front desk, I come back and the team has changed. Like the anesthesiologist who was part of the initial huddle is now off on break. The SCDs aren't on, and the challenge that I find is finances are a great motivator for physicians if you're cutting our payments, but it's not like anybody else. It's not like the staff in the OR who are responsible for executing those plans. In other words, if I'm operating, I can't prevent people from going in and out of the room, but yet I'm the one who takes the financial hit, or ultimately who takes a financial hit, and the people who are going in and out of the room don't take a financial hit. So while in theory I agree with everything, I just wonder how the physicians or the people on committees that you've dealt with have kind of addressed that issue of different members of the team have very different kind of financial and professional motivations and reward systems.
I mean, I think you make a great point. I think that this is one of the big, not the number one struggle on sort of implementing these things. And I can tell you, I operate mostly at 3 hospitals, one of which is an ambulatory center, which is part of a hospital. And I can tell you, within those 3 hospitals, which are located very close together, the spectrum of adoption of these types of things was vastly different. So, there was the one hospital that totally bought in and got it from the beginning, and it was easy. Then I had another one, which was like what you're talking about. It's like, nobody cared, I don't believe this. And so, what needs to happen, and, remember, the hospitals are under the same pressures. You have to really create an environment of care where everybody believes in this, and also there's some accountability. You have to, and creating the environment of care, I think, is what develops the accountability. So, for example, at that one hospital, certain parts of the team, didn't care. There wasn't the financial, punishment, so to speak, if they didn't do something. So, they didn't quite care. So if the DVT boots weren't on right away, they didn't have to deal with the patient's PE postoperatively. But what has actually come out of all this is the monitoring of the outcomes related to the patient, so that when that patient has a PE or that patient has a DVT or there's some type of bad outcome, they come back and they now look at everybody involved, and there are repercussions for those who haven't followed the protocol, be it in evaluations or whatnot. But I agree with you totally. That is the most potentially frustrating part of this. But the reality is that environment of care, sort of has to be created, and it's just there are early adopters and there are late adopters, and the late adopters are eventually going to have to come into play and adopt all this. Other questions? So we're just at an hour. I can thank you all for inviting me. Hopefully this was informative and helpful. I'm always available if things come up in your hospitals. I'm always willing to take phone calls from anybody, any member, on a related issue or something different related to the topic.
Thank you very much. This was great. I mean, this is coming from somebody who, until tonight, I couldn't even tell you what an SGR was. So thank you very much.
Thanks again.
Thanks, Scott.
Have a good night, everybody.
Bye.
Thank you. Please stand by.